Tips to manage a posterior capsule tear with vitreous prolapse. If a posterior tear is noted, the surgeon should stop operating but not remove the instruments from the eye. If one removes the phaco probe or the INA instrument immediately, vitreous will follow, increasing the likelihood of a retinal tear. Instead, stop the flow but do not remove any instrument. Ask the scrub nurse to hand you the vial of viscoelastic. When ready, gently remove the second instrument from the paracentesis and replace it with the viscoelastic cannula and fill the anterior chamber with viscoelastic. Once achieved, the phaco probe or INA cannula can then also be safely removed without inducing further prolapse out of the section. Ask the nurses to prepare the vitractor and to set the cutting rate to high, which is usually 350 cuts per minute or higher. Always do bimanual vitrectomy. In this case, a butterfly cannula is set up as a separate infusion line. Enlarge the paracentesis to ensure the vitractor will also pass through it. Introduce the infusion cannula through the second incision, directing it away from the capsular tear. Position it in a safe, stable position. Pass the vitractor through the capsular rent into the anterior vitreous and commence cutting, drawing vitreous back into the posterior segment. Do not touch the anterior capsular axis, which can be used as a shelf to support an IOL in the sulcus and allow optic capture. Clear the whole anterior chamber of vitreous and sweep across the pupil with the infusion needle to ensure no vitreous strands are present. Change positions with the vitractor instrument. Clear both openings of any vitreous strand. After vitrectomy, open the section to allow placement of the IOL and ensure that no vitreous strands are present by sweeping again with another instrument prior to insertion of the IOL.